It's funny. When you're first learning to drive, they really hammer this one concept into your head over and over again. Defensive driving.
Oh, yeah. Like constantly looking out for the other guy.
Right. You're taught to never just assume that the person in the lane next to you is actually going to use their turn signal or, that the car at the red light is actually going to stop.
Yeah, you basically have to operate under this assumption that everyone else is going to do something totally unpredictable.
Exactly. So you always wear your seatbelt. You check your mirrors, even when you technically have the right of way. You build this sort of invisible buffer around yourself.
Because you don't wait for the screech of tires to suddenly, reach over and grab your seatbelt. By then, the physics of the crash are already in motion. You're too late.
Right, you have to establish that universal baseline of safety before you even put the car in gear. Well, welcome back, everyone, to another deep dive. We are incredibly pumped to have you here with us today. Just to give you a quick lay of the land, if you're new here, this deep dive is part of our special Cert Prep Academy CNA exam prep series.
We are running an 11-part deep dive covering all 6 of the NNAAP written exam topics.
And even though it is a structured series, each one of these deep dives stands completely on its own. So if you are prepping for your exam and you feel, totally confident in basic nursing skills, but you're struggling with, say, client rights.
You can just jump around to whatever topic you need most right now. You really don't have to listen in linear order.
Right. So for today, we are on part 8. Infection Control Part 2, and we're specifically focusing on isolation precautions and disease transmission.
Which, honestly, sounds like a massive textbook chapter.
It really does. But we are going to break it down, pull apart the actual mechanics of these protocols, and hopefully make it all feel a lot more intuitive for you.
And we really have to, because the stakes for this specific material are remarkably high. If we look at the National Council of State Boards of Nursing, the NCSBN, their job analysis basically dictates the blueprint of your entire exam.
Yeah, it's the master key.
Exactly. And the basic nursing skills category makes up a whopping 39% of the entire written test.
39%. I mean, that's almost half the exam resting on this one umbrella category.
Yeah, so out of the 70 scored multiple choice questions you're going to face, 23 of them pulled directly from this section. And infection control is essentially the central pillar holding that entire section up.
Because it's the foundation of everything else you do as a nurse aide.
Precisely. You cannot perform safe ADLs, you can't take accurate vital signs, and you definitely cannot assist with mobility if you're actively acting as a vector for disease.
So 23 questions, that's the literal difference between passing and failing.
It really is.
So our mission for this deep dive is pretty straightforward. We are taking actual practice questions from the source material. We're breaking down these different precaution types, and we are not just going to memorize the right answers. We want to figure out why the wrong answers are set up as traps.
Because the NNAAP exam is notorious for offering you an answer that sounds logically plausible if you're panicking.
Right, like it makes sense in the moment.
Yeah, but it's fundamentally flawed if you understand the actual science behind it. They want to evaluate your critical thinking in a high-stress moment.
They aren't just testing if you know what an N95 mask is.
No, they are testing if you know when to reach for it. And honestly, more importantly, when reaching for it is the absolute wrong move.
Yeah. So before we get into the really intense clinical setups, the negative pressure rooms, the respirators, the pathogens floating in the air, we have to start with that baseline.
Standard precaution.
Right. Going back to that driving analogy, you can't understand the complex defensive maneuvers on an icy highway if you don't understand that the seatbelt applies on a sunny day in an empty parking lot.
That's a great way to put it. Standard precautions apply to all patients, every single one, in every single healthcare setting.
Regardless of their diagnosis.
Regardless of their diagnosis, and regardless of their known infection status. And the why behind that is a massive hurdle for a lot of test takers, I think.
Because human nature makes us assume that if someone has an infectious disease, there will be visible signs, right? Like a cough or a rash or a fever.
Exactly. But the daily reality of healthcare is that a huge percentage of your patients are asymptomatic carriers.
They feel fine, they look totally fine, their chart doesn't have any big red flags on it.
But they are harboring a pathogen that could be devastating to, say, the immunocompromised patient 2 doors down. They might be colonized with MRSA in their nasal passages and have absolutely no idea.
Which brings up a practice scenario in the materials. Question 21 specifically targets this concept. It asks for the best description of standard precautions.
And the trap answers there are so tricky. They suggest that these precautions apply only in isolation rooms or that they involve hand-washing practices performed like once per shift.
Once per shift.
Right. Both of those are incredibly dangerous misconceptions that reflect just a total misunderstanding of epidemiology. Standard precautions are your everyday, every patient baseline defense mechanism.
Let's look at another scenario from the sources that illustrates how this gets twisted on the exam. Question 13. You have a patient with a urinary tract infection, a UTI. They are not on any specific isolation precautions.
Okay.
The question asks if you should wear any special PPE beyond standard precautions, and the trap answer that catches so many people is, yes, airborne precautions if the patient has a fever.
Oh, man. That is a masterclass in how test writers manipulate your anxiety.
It really is.
They throw the word infection and the word fever at you to trigger this panic response. You see fever and your brain immediately jumps to, contagious, dangerous, get the heavy-duty gear on.
But you have to pause and look at the actual pathophysiology of the disease and its route of transmission.
Right. The UTI is an infection of the urinary tract. It's E. coli or another bacteria trapped inside the bladder or the urethra. It's a closed system.
It's not a respiratory virus. It's not hanging out in the air when the patient exhales or talks to you.
Exactly. UTIs are not communicable through the air. And they aren't communicable through casual skin-to-skin contact in the way a superficial skin infection might be. So standard precautions, which means you are wearing gloves when you are directly handling urine, emptying a catheter bag, or providing perineal care.
And you're practicing strict hand hygiene?
Yes, that is perfectly sufficient. You don't need a negative pressure room for a bladder infection. Upgrading their isolation status just based on a fever is a massive waste of resources, and it improperly restricts the patient's movement.
So if standard precautions are the baseline, the undeniable golden rule of this whole system is hand hygiene.
Right.
It's the mechanism that makes the rest of the precautions actually work.
If we zoom out and look at the bigger picture of healthcare-associated infections, HAIs, hand hygiene is the single most effective, evidence-based way to prevent them.
Question 15 from the source material hits this point directly. The trap answer suggests things like administering prophylactic antibiotics to everyone or severely limiting patient visitation.
Which, giving antibiotics to everyone as a preventative measure is just a recipe for creating superbugs.
Yeah, that's exactly how we get methicillin-resistant and vancomycin-resistant bacteria in the first place.
And completely shutting down visitation has severe psychological impacts on patients. It's not a sustainable primary defense. The core defense is washing your hands, because the microscopic world is largely a touch-based world.
This is a classic Cert Prep Academy question on transmission routes, actually. People always guess that airborne spread is the biggest danger in a hospital because it just sounds the scariest.
An invisible cloud of germs.
Right. But it's really the contaminated hands of healthcare workers and contaminated environmental surfaces. That is the #1 way infections move from room A to room B.
Which brings us to the specifics of how we wash. Because doing it improperly is functionally the same as not doing it at all. According to the CDC and WHO guidelines referenced in question 16, there is a minimum recommended length of time you must scrub with soap and water.
20 seconds, minimum. And let's be real, 20 seconds feels like an eternity. When you are standing at a sink in a busy hallway, you have like 3 call lights blinking, and your charge nurse is looking for you.
It really does. But the wrong answers on the test are usually 10 seconds, which is just too brief to physically remove the flora, or 45 seconds to a minute.
Which is fine, but it's overkill for standard practice.
Yeah, and it will eventually lead to severe skin breakdown if you do it 50 times a shift. It's crucial to understand the mechanics of what soap is actually doing here.
Okay, break that down for us.
So soap molecules are amphiphilic. One end loves water, the other end loves fats and oils.
Right. The bacteria and viruses on your hands are largely encased in lipid layers, which is fats, and they cling to the natural oils on your skin. When you use soap and friction, those soap molecules are literally wedging themselves into the lipid envelopes of the pathogens and ripping them apart.
Wow, okay.
While simultaneously lifting the oils off your skin so the water can just wash them down the drain. That chemical and physical process takes time. 10 seconds just isn't enough time for the mechanical friction to break those bonds.
And you can't just casually rub your palms together either. Question 22 addresses the geography of your hands. You have to wash all the way up to your wrists.
The wrists and the lower forearms are highly problematic areas in healthcare. Think about your uniform. Think about your gloves, the cuffs of your gloves, and right at the wrist. The cuffs of your scrub top often rest right around the lower forearm.
So it's a natural gathering point for pathogens.
It is.
I never really thought about the glove cuff acting like a little collection rim, gathering bacteria right at the pulse points. That's exactly what happens,
Yeah.
especially when you are removing contaminated PPE. The friction of pulling the glove off can deposit flora right at the wrist line.
Mm-hmm.
If you only wash your fingers and palms, you are leaving a concentrated ring of bacteria on your skin. The next time you touch a patient's bed rail or adjust their IV tubing with your forearm brushing against it, you've just transmitted the pathogen.
Man. The exam also hammers home when we are doing this, obviously before direct patient contact. But question 24 is entirely focused on the post-care routine. You have to wash your hands immediately after removing gloves.
Because there's this pervasive myth among healthcare students that gloves are an impenetrable force field.
Yeah, I wore gloves the whole time, so my hands are clean.
Exactly. The logic goes, I'll just wait and wash them when I go on break.
Yeah.
That is a fatal flaw in infection control.
Because gloves are manufactured by the millions. They're thin latex, nitrile, or vinyl. They are not magic armor.
No, they can have microscopic tears. Pinholes that are completely invisible to the naked eye but are massive doorways for a virus.
Right.
Furthermore, the very act of taking a dirty glove off means your freshly exposed, warm, slightly sweaty hand is in incredibly close proximity to the contaminated outer surface of that glove. You have to assume your hands are compromised the absolute second those gloves come off.
Let's touch on hand sanitizer really quick because the reality of the floor is that you use alcohol-based rubs constantly. Question 30 brings this up. Does the amount of sanitizer you pump out actually matter?
Oh, absolutely. The trap answer on the exam is that a tiny drop is sufficient. But the physics of alcohol-based sanitizers require thorough coverage.
Right, because alcohol kills bacteria by denaturing their proteins.
Yes, but it needs to remain wet on the surface of the pathogen long enough to work. If you use a tiny drop, it evaporates almost instantly.
So your hands are dry in 3 seconds and you think you're good to go.
But you haven't achieved the contact time required to actually denature the proteins. You need enough product to thoroughly coat all surfaces of your hands, between the fingers, the backs of the hands, the thumbs, and the wrists. And you have to rub them together until they are completely dry naturally.
No wiping them on your pants to speed it up.
Exactly. Let them air dry.
Okay, so we've locked in the baseline. We know how to wash, when to wash, and that standard precautions are our everyday defensive driving. But what happens when the road is actively iced over? What happens when defensive driving isn't enough because there is a known, highly transmissible threat in the room?
That brings us to contact precautions and the absolute art form that is personal protective equipment, or PPE.
Yes. We are moving from the universal baseline to targeted interventions. Contact precautions are designed for pathogens that spread through direct touch, so skin-to-skin contact with the patient or indirect touch.
Meaning contact with fomites in the patient's environment.
Right. Fomites being inanimate objects, bed rails, blood pressure cuffs, call lights, the television remote. And the poster child for contact precautions on the NNAAP exam is MRSA, methicillin-resistant Staphylococcus aureus.
That's the big one.
Question 3 spells this out clearly. If a patient with MRSA is admitted, you are required to use contact precautions, which means gowns and gloves.
Let's analyze why the wrong answers for the MRSA question are so tempting to test takers. The exam will offer you droplet precautions with a surgical mask as a primary option for MRSA.
And if you are rushing, you see an infectious disease and you just think, masks.
Exactly. But MRSA is primarily a skin and wound infection. It colonizes in the nares, the nostrils, and lives on the skin surface. It forms incredibly resilient biofilms on environmental surfaces.
It can survive on a plastic bed rail for days, even weeks under the right conditions.
So if you walk into that room wearing a surgical mask but no gown, you are fixing a touch problem with an air solution. The mask does absolutely nothing to stop a bacteria that is actively hitching a ride on your scrub top when you lean over the bed to adjust the patient's pillows.
You have mismatched the intervention to the mechanism of transmission. You need the gown to protect your uniform from becoming a fomite, and you need the gloves to protect your hands.
Precisely.
This actually brings up a point in the source material that genuinely confused me when I was reviewing my notes for this deep dive. I found a clear contradiction in the practice questions regarding the order of putting on PPE. The donning sequence.
Oh, boy. This is a notorious pain point in nursing education. Walk me through what you found.
Okay, so question 12 lays out a donning sequence. It says the correct order is mask, eye protection, gown, gloves. But then I cross-referenced that with question 18, and it says gown first, then mask, eye protection, and gloves last. I mean, which one is it? Is the exam material flawed?
You aren't misreading it, and you certainly aren't going crazy. Different textbooks, different facility protocols, and even different branches of the CDC sometimes prioritize the sequence of donning differently depending on the specific physical layout of the anteroom or the specific isolation scenario.
That is so frustrating for a standardized test.
It is. But if you look closely at both of those sequences, what is the universal anchor? What is the one step that does not change?
Well, in both of those questions, the very last thing you put on is the gloves.
Gloves always go on last.
Yeah.
That is the ironclad rule the NNAAP exam is testing. The reason for this is entirely structural.
Okay, how so?
The gloves have to be pulled up and over the knitted cuffs of the isolation gown to create a seamless, continuous barrier.
Oh, I see. If you put your gloves on first and then try to wrestle your arms into a gown, the long sleeves of the gown are going to push the gloves down your hands.
Right. You'll end up with an inch of exposed skin at your wrists. And as we already discussed, the wrists are prime real estate for bacterial collection. By putting the gloves on last, you stretch the elastic over the gown cuff, completely sealing off the arm. The sequence before the gloves might have slight variations, but if you see a multiple choice option where gloves are put on anywhere other than last, you can immediately eliminate it as a trap.
That clears up so much confusion. Now that is putting the gear on. Taking it off doffing is where the real danger lies. The NNAAP exam is incredibly strict about the doffing sequence because this is the moment where healthcare workers most frequently contaminate themselves.
It's the most high-risk part of the process.
Question 5 lays out the exact order. The absolute correct sequence for removing PPE is gloves first, then the gown, then eye protection, and the mask is removed absolute last.
Let's challenge the intuition here. Why do you think people struggle with this specific sequence?
Because it feels totally counterintuitive. If I'm wearing a tight mask and a plastic face shield and it's hot in the room, the very first thing I want to do is get that stuff off my face so I can breathe properly. It feels suffocating. Why is the mask the very last thing to go?
It's an entirely natural human instinct to want to uncover your face.
Yeah.
But think about the physics of what you are doing when you remove a contaminated gown.
Okay.
You have been in an isolation room, providing care. The front of that gown is covered in microscopic particulate matter. When you grab that gown to tear it off, you are pulling at fabric, you are unrolling it, you are shaking the physical material.
You're basically kicking up a microscopic dust cloud.
Exactly. Doffing a gown is an aerosolizing event. The mechanical action of crumbling the gown into a ball disrupts the settled particles and creates a localized, invisible cloud of whatever was on that gown right in your immediate breathing zone.
Oh, wow.
If you have already removed your mask, you have stripped away your respiratory protection right before you intentionally shake up a blanket of pathogens under your own chin.
That is such a vivid image. I am literally never going to forget that. You leave the mask on to protect yourself from the mess you make while taking the rest of the gear off.
You got it. The gloves come off first because they are the most heavily contaminated element. They have had direct physical contact with the patient. You use glove-to-glove and skin-to-skin removal techniques so your bare hands never touch the outside of the gloves.
Right.
Then you remove the gown, carefully pulling it away from your body and rolling it inside out, trapping the contaminated exterior on the inside of the bundle.
And the source material doesn't always explicitly state this mid-step, but best practice dictates performing hand hygiene right after the gown comes off before you reach up to your face to remove the eye protection and the mask.
Yes, always wash before touching your face. And when you finally remove the mask, you only handle it by the ear loops or the ties behind your head. You never touch the front filter piece.
Because it's been acting as a net, catching particles the entire time you're in the room.
Right.
There is another massive exam mistake tied to the gown removal, specifically regarding where it happens. Question 4 and question 29 both hammer this point. When and where do you remove the isolation gown?
And the trap answers will say, remove it at the end of your shift, or remove it in the hallway outside the room.
Which sounds convenient, especially if the trash can inside the room is full. But the correct answer is that you must remove the gown immediately after patient contact before leaving the patient's room, usually right by the door.
If you wear a contaminated gown out into the hallway, you cease to be a healthcare provider and you become a walking vector.
Right.
The hallways of a healthcare facility are supposed to be clean zones. Every breeze you create as you walk, every door frame you brush against, you are shedding that patient's isolation-level pathogens to the rest of the facility. You shed it onto the medication cart, the charting station, the break room chair. The gown stays in the room, period.
Let's talk about gloves again, because there are a ton of specific rules about when to change them during active care. Question 19 and question 25 delve into this. Obviously, everyone knows you change gloves between different patients. You don't walk from room A to room B wearing the same gloves.
No, absolutely not.
But the test emphasizes that you also have to change gloves between tasks on the same patient.
This one often confuses students. If it is all the same patient's germs anyway, what is the practical difference? Why go through the hassle of degloving, washing, and regloving if I haven't left the bedside?
Well, it's all about the location of the body's natural flora. The human body has distinct microbiomes. The bacteria in your digestive tract are fundamentally different from the bacteria in your respiratory tract, which are different from the bacteria on your skin.
Exactly. Let's look at a practical clinical scenario. You are providing morning care. You start by providing perineal care after a brief episode of incontinence. The perineal area is heavily populated with digestive tract bacteria, notably E. coli.
Okay.
If you finish that task and then immediately move to provide oral care, or adjust the patient's oxygen cannula, or tend to a minor skin tear on their arm using those exact same gloves.
You have just translocated E. coli directly into their mouth, their respiratory tract, or their bloodstream. You are actively causing a healthcare-associated infection in your own patient.
Exactly. Strip Prep Academy breaks down the different precaution types really clearly, but I remember that specific rule about changing gloves on the same patient when moving from a contaminated area to a clean area is one of their absolute best flashcards.
Yeah, it's one of those protocols that sounds like administrative overkill until you understand the underlying anatomical logic.
It's all about protecting the patient from their own microbiome.
Okay, so we have thoroughly covered the touch-based protocols. We know how to handle fomites and skin flora. Let's look up. We are moving into droplet versus airborne precautions.
This is where the physics of disease transmission gets hyper-specific.
It really does. You have to understand the aerodynamics of how different pathogens travel through physical space.
Let's start with droplet precautions. These are designed for pathogens that travel inside large respiratory droplets.
So heavy droplets.
Yes, relatively speaking, they are heavy. When a patient coughs, sneezes, or even talks loudly, they eject mucus and saliva from their respiratory tract. These droplets contain the virus or bacteria.
Yeah.
But because the droplets contain a significant amount of water weight, gravity exerts a strong pull on them. They are pulled down to the floor or onto nearby surfaces fairly rapidly. They don't have the physical properties required to float around the room indefinitely.
Generally, these large droplets only travel about 3 to 6 feet from the source before they hit the ground. Question 7 gives us a primary example of this. Standard seasonal influenza, the flu.
Yes.
If a patient is admitted with the flu, they are placed on droplet precautions. What kind of environmental setup does that require?
According to question 2's explanation in the source material, the ideal setup is a private room. If a private room is absolutely unavailable due to capacity issues, the acceptable alternative is to cohort them.
Cohorting meaning putting them in a shared room with a patient who has a confirmed diagnosis of the exact same infection. You can put 2 flu patients together.
Right. And what kind of respiratory protection are we wearing when we walk into that room?
A standard surgical mask. It provides an adequate physical barrier against these large, heavy droplets.
However, there are strict rules for maintaining the integrity of that mask. You cannot just strap a single surgical mask to your face at 7 a.m. and wear it for a 12-hour shift.
No way.
The source material dictates it must be changed every 2 to 4 hours, or immediately if it becomes damp or soiled.
Why does dampness compromise the mask, though? It's just water, right?
It's not just a piece of paper. A surgical mask works through a combination of physical barrier layers and electrostatic charge.
Okay.
The middle layer of the mask is melt-blown polymer that carries a static charge, which actively traps particles. When the mask gets wet, whether that's from a splash of fluid or just the condensation of your own breath over a few hours, the moisture degrades the physical integrity of the filter.
Ah, so the static charge is gone.
The electrostatic charge is neutralized, and pathogens can basically wick right through the wet material via capillary action.
So a wet mask is a useless mask. Change it out. And question 26 is a gentle but necessary reminder that the mask has to securely cover both the nose and the mouth.
Oh, the chin diaper look.
Yeah. Wearing a mask pulled down under your nose or resting on your chin is functionally identical to not wearing a mask at all. The respiratory tract is a continuous system. Leaving the nares exposed defeats the entire purpose.
Let's contrast those heavy droplets with airborne precautions. If droplet pathogens are heavy and fall quickly, airborne pathogens are the exact opposite. They are carried on what epidemiologists call droplet nuclei.
Droplet nuclei. What is the physical difference between a droplet and a droplet nucleus?
Think of a droplet nucleus as the dried-out, microscopic leftover core of a respiratory droplet. When a patient with an airborne disease coughs, they expel droplets. But because these specific droplets are so incredibly tiny, usually less than 5 microns in diameter, the water content evaporates into the air almost instantly.
Okay, so they dry up.
Exactly.
Right.
What is left behind is just this nearly weightless speck of infectious biological material.
And because they are so light, gravity has very little immediate effect on them. They defy gravity. They can remain suspended in the ambient air currents of a room for hours.
Which is why standard surgical masks are completely useless against airborne pathogens. A surgical mask doesn't seal tightly around the cheeks and chin. Air flows freely around the edges.
Right.
Furthermore, the filter material isn't dense enough to trap particles that small. For airborne precautions, the classic example from the exam mentioned in question 7 is tuberculosis, or TB.
For a TB patient, the physical environment has to be fundamentally altered. You need a negative pressure room. Let's break down how a negative pressure room actually works, because it's a brilliant piece of engineering.
It really is. A negative pressure room, also known as an airborne infection isolation room, is connected to a specialized HVAC ventilation system. The system is calibrated to pull more cubic feet of air OUT of the room through an exhaust vent than it pumps in through the supply vent.
Creating a vacuum.
Yes. This constant imbalance creates a slight vacuum effect inside the room.
So, when a nurse opens the door to the hallway to walk in, the air from the clean hallway physically rushes into the room to fill the vacuum. The contaminated, infectious air from inside the room is fighting against that current and is never allowed to leak OUT into the hallway.
Precisely. The contaminated air is constantly being sucked out of the room, pulled through massive HEPA filters that trap the bacteria, and then safely exhausted out of the building. To enter this environment, healthcare workers must wear an N95 respirator. Questions 32 and 5 outline the requirements for this.
And the 95 in N95 literally means that when the mask is properly fitted, it filters out at least 95% of these tiny 0.3 micron airborne particles. But the key phrase there is properly fitted.
You cannot just grab an N95 off a shelf and assume you are protected. You must undergo a formal fit testing process.
Right.
This usually involves putting a hood over your head and having a safety officer spray a bitter or sweet aerosolized solution into the hood while you wear the mask. If you can taste the solution, the mask is linking around the edges of your face, and it fails. The seal must be absolutely perfect.
Now, here's a massive trick question from the exam that catches so many people off guard. Question 3. A patient is admitted with chickenpox, also known as varicella. What isolation precautions do they require?
The trap is assuming diseases fit neatly into only one category. The correct answer for varicella is both airborne and contact precautions simultaneously.
Why the dual requirement?
Because of the complex nature of the varicella zoster virus, the virus aggressively replicates in the respiratory tract. When the patient breathes, speaks, or coughs, they are exhaling the virus via those tiny suspended droplet nuclei.
Okay.
That route of transmission mandates the negative pressure room and the N95 respirator.
But varicella is famous for the itchy, blister-like rash it causes all over the body.
Yes, and the fluid inside those individual skin lesions is heavily saturated with the live virus. The virus sheds continuously from the blisters. If you touch the rash or if you touch the bed sheets that the rash has been rubbing against, you can contract the virus through physical contact.
So you need the gown and gloves to protect your skin and uniform from the physical lesions, and you need the N95 and negative pressure to protect your lungs from the ambient air. It's a dual threat. If you only implement one precaution, you leave a massive vulnerability.
Exactly. Now, let's consider a logistical challenge with airborne patients. Say our TB patient is in their negative pressure room, but they need to go down to the radiology department for a chest x-ray.
You can't bring the MRI or the big x-ray machine to them. They have to travel through the clean hallways of the hospital.
Right. Question 9 asks what the patient should wear during transport.
And the correct answer on the exam is a standard surgical mask.
which is the massive point of confusion for students, and it's easy to see why.
Yeah, I'm going to push back here because logically it just feels wrong. If they have a highly contagious airborne disease and I have to wear a heavy-duty N95 respirator just to step foot in their room,
Right.
why wouldn't we strap an N95 onto the patient before parading them through the public hallway?
That seems like common sense, right?
Right. Wouldn't that offer the most protection to the rest of the hospital?
It is a totally logical assumption, but it fundamentally misunderstands how these two different masks are engineered to function. An N95 respirator is an inhalation filter. It is designed to be tightly sealed to protect the healthy worker from breathing incoming pathogens.
Okay.
It requires significant lung power to pull air through that dense filter material. A standard surgical mask, however, is designed as source control. It is meant to block outgoing particles from the person wearing it.
Oh, wait. So we put the surgical mask on the patient to catch the heavy droplets of moisture right at their mouth before those droplets have a chance to evaporate into the tiny floating nuclei.
Exactly. If we trap the moisture at the source as they exhale, we completely neutralize the airborne threat. Furthermore, putting a tightly sealed N95 on a sick patient, especially a TB patient who already has severely compromised lung function, can make it dangerously difficult for them to breathe.
Yeah, they could become hypoxic during transport.
A surgical mask is the correct tool for source control.
Yeah, we see students get this exact transport question wrong on Cert Prep Academy all the time. It's such a subtle distinction, but when you understand the physical mechanics, the N95 as the incoming filter for the healthy worker and the surgical mask as the outgoing catcher for the sick patient, it makes perfect sense.
We have excellent theoretical models for how this should all work. We have the negative pressure rooms, the specific doffing sequences, the correct transport protocols. But nursing does not happen in a vacuum. It happens in the real world, where the best laid plans fall apart in a matter of seconds.
Which brings us to handling the unexpected, the real-world floor scenarios. Theory is great, studying flashcards is great, but the NNAAP exam really wants to know, what do you do when the protocol breaks? How do you react in sudden, chaotic moments?
The exam uses these situational judgment questions to evaluate your ability to prioritize under pressure. Let's run through a few of these, starting with scenario 1, pulled from question 6.
Okay, set the scene.
You are in a patient's room providing routine, direct care. You do not have a mask on because standard precautions did not indicate the need for one. Suddenly, without warning, the patient sneezes violently right in your direction. What is your immediate primary action?
The trap answers here are so tempting because they sound like responsible nursing actions. One trap says, wash your hands and monitor yourself for symptoms. Another says, immediately notify infection control and document the exposure in the patient's chart.
Both of those are things you absolutely will do eventually. But the question is asking for your immediate action, the very next chronological step. The correct answer is immediately step back and put on a mask.
Right. You have to stop the active exposure first. If you turn your back to walk to the sink to wash your hands, you are remaining in the invisible cloud of respiratory droplets while you scrub for 20 seconds. Hand hygiene delays the immediate protective action you need to take for your own respiratory tract.
Step back. Increase the physical distance and mask up. Secure the airway first. Let's escalate the severity. Scenario 2, drawn from question 27 and question 4. You're assisting a nurse with a complex hygiene task, or perhaps emptying a surgical drain, and you get splashed directly in the eye with body fluid or blood.
First of all, that is an absolute nightmare scenario.
Terrifying.
But the correct action is clear. Stop the task immediately, proceed to an eye wash station or sink, and rinse your eye with copious amounts of water for at least 15 minutes, then report it immediately to the charge nurse.
Why are the wrong answers so dangerous here? Why is the eye so vulnerable?
Well, one of the trap answers says, wait to see if any symptoms develop before reporting, which is insane. The mucous membranes of the eye do not have the protective, keratinized outer layer that your skin has. They are highly permeable. Pathogens can bypass the physical barrier and enter the bloodstream almost instantly.
Instant access.
Yeah. If you have been exposed to hepatitis C or HIV, waiting for symptoms to appear means you have completely missed the critical window for post-exposure prophylaxis. The emergency antiviral medications that can actually stop the virus from permanently taking hold in your body.
Time is tissue, and in this case, time is immunity. You do not wait. Scenario 3 deals with another critical exposure route, needle sticks.
Oh,
Question
why?
8. You are assisting with a procedure or perhaps handling improperly disposed trash, and you accidentally stick yourself with a used contaminated needle.
I know exactly what the instinct is here. If I get stuck by a needle, my immediate visceral reaction is to squeeze the puncture wound as hard as I can to make it bleed out the bad stuff.
It is a nearly universal human instinct. But the exam explicitly states that squeezing the wound is the wrong action. Why?
Because of the mechanics of capillary refill.
Yeah.
When you aggressively squeeze the tissue around a puncture wound, you force blood out, yes. But the moment you release the pressure, the tissue expands and creates a microvacuum, which can actually pull surface fluids and the pathogen deeper into the capillary beds via capillary action.
Wow.
You are actively helping the virus travel further into your system.
Exactly. The mechanical pressure does more harm than good. The absolute first thing you do is wash the wound gently with soap and flowing water. Let the water flush the site. You don't just slap a bandage on it to hide it, and you don't run down the hallway to find the charge nurse while your finger's actively bleeding contaminated blood.
Core.
Wash first, then report.
And obviously, as question 1 points out, sharps always go in designated puncture-resistant red biohazard containers. Never, ever the regular trash, because that is how environmental services workers get stuck.
Let's shift gears slightly and talk about compliance and interpersonal conflict. Because dealing with pathogens is hard, but dealing with human behavior on a stressful hospital floor can be even harder. Scenario 4 from question 11. You are walking down the hall and you observe a colleague about to enter a room to provide care for a patient with hepatitis B. You notice they are not wearing gloves.
This corrosion is a brilliant intersection of infection control knowledge and professional ethics. Hepatitis B is a viral infection transmitted via blood and bodily fluids. It is incredibly hardy. It can survive outside the body on environmental surfaces for up to 7 days and still cause infection. It is highly contagious.
The trap answer on the test is, say nothing to avoid conflict, as they are a licensed professional, or something to that effect.
Which is an unacceptable response. You are part of a cohesive healthcare team. The hierarchy of the floor does not supersede patient safety, nor does it supersede staff safety.
It's intimidating, though. If you are a brand new CNA and the person forgetting their gloves is a nurse who has been working there for 20 years, the power dynamic makes it incredibly uncomfortable to speak up.
It is uncomfortable, but silence implies consent to a dangerous practice. The correct action is to politely, professionally point out that gloves are required for this patient. You don't have to shout at them or immediately run to report them to management if a gentle, immediate reminder solves the problem. But you cannot stay silent. You are an advocate for safety.
I love that. Be an advocate even when it's awkward. Let's look at a scenario involving patient behavior. Scenario 5, question 14. You have a patient who's suffering from moderate dementia. They are on contact precautions, but they don't understand why they are isolated. They keep wandering over to their door, pulling down the isolation precaution signs and trying to leave the room.
This is a classic behavioral challenge that pits safety protocols against patient rights. The trap answers on the exam offer extreme, unethical solutions. One trap suggests using physical restraints to keep the patient in bed and stop them from removing the signs.
Which is a massive, immediate violation of client rights. We never, ever use physical or chemical restraints for staff convenience or to enforce isolation protocols. That is illegal and unethical.
The other trap is the path of least resistance. Document the behavior in the chart and do nothing else as the patient is non-compliant.
But doing nothing puts the entire facility at risk. If those isolation signs are down, another staff member, dietary aide, or visitor might walk right into that room without donning the proper PPE and get exposed.
So the correct middle ground action is replace the signs repeatedly, as many times as it physically takes, and immediately notify the nurse.
By notifying the nurse, you are escalating the safety concern so the care team can arrange for alternative interventions.
Yeah.
Perhaps the patient needs a one-to-one sitter, or perhaps they need to be moved to a room closer to the nursing station for closer observation. You manage the immediate physical environment by replacing the sign, and you manage the long-term risk by communicating up the chain of command.
Let's do one final scenario. Scenario 6, drawn from questions 1 and 23. You are taking morning vitals on a patient who is admitted for a broken hip. They are not on any isolation precautions. But as you are taking their blood pressure, you notice they have developed a new, wet, productive cough. They are flushed, and their temperature is 101.5.
You have recognized new signs of a potential respiratory infection. The trap here relies on an overeager test taker. The trap answer is, Immediately place an airborne precaution sign on the door and don an N95.
You cannot do that. Initiating medical isolation protocols, ordering specialized rooms, or upgrading a patient's diagnostic status is completely outside the CNA scope of practice. You don't have the authority to unilaterally declare someone is infectious.
But the opposite trap is equally dangerous. Wait to see if the fever breaks and document the cough at the end of your shift.
Waiting means every person who walks into that room for the next 8 hours is walking into an unprotected exposure event. The correct action is the gold standard of nursing assistant practice. Notify the nurse immediately.
You collect the data, you recognize the deviation from the baseline, and you pass that critical information up the chain of command instantly. You give the nurse the clinical puzzle pieces so they can assess the patient, consult the physician, and officially implement the correct precautions. You are the eyes and ears of the floor.
You know, if you are ever stuck on these scenario questions during your studying, running through the practice tests on Cert Prep Academy really helps train your brain to spot the safest, most immediate action.
Yeah, that repetition is key.
The questions are designed to trick you into overstepping your scope of practice or delaying care. Doing the repetitions builds that muscle memory for the exam.
It absolutely does. Familiarity with the structure of the traps is just as important as familiarity with the clinical material itself. As we wrap up this deep dive, I want to leave you with a final, broader thought to mull over.
Lay it on us.
We spend so much time in these study sessions, and in healthcare in general, thinking defensively. We think about how to protect ourselves from the patients. We focus on the N95 masks, the impermeable gowns, the double gloving, the safety needles, and that self-preservation is entirely necessary.
Of course.
But remember, the ultimate goal of infection control. When you perfectly execute hand hygiene for 20 seconds, when you take the extra time to doff your PPE in the exact right sequence so you don't aerosolize those pathogens, you aren't just protecting yourself. You are actively protecting your next patient.
Oh.
The elderly woman recovering from surgery next door, the immunocompromised patient down the hall. You are preventing the microscopic world of the sick room from hitching a ride on your scrubs and invading a vulnerable person's space. You are the physical shield between the illness and the rest of the facility. That is the true weight of standard precautions.
You are the shield. That is such a powerful, dignified way to look at a task as repetitive as washing your hands. It elevates the daily grind into a profound responsibility.
It really does.
All right, let's do our rapid-fire 1-minute recap to lock all of these concepts in before you go. Standard precautions apply to everyone, everywhere, all the time. Wash your hands for at least 20 seconds with friction, all the way up to the wrists. Hand sanitizer must coat all surfaces and dry naturally.
When you don PPE, the absolute rule is gloves go on last to seal the cuffs.
When you doff PPE, gloves come off first and your mask comes off absolute last to protect your airway from the dust cloud.
Contact precautions mean gowns and gloves. Think fomites and MRSA.
Droplet precautions require private rooms or cohorting and standard surgical masks. Think heavy particles and the flu.
Airborne precautions require negative pressure rooms and fit-tested N95 respirators. Think floating nuclei, tuberculosis, and chickenpox.
And remember, chickenpox is a dual threat, airborne and contact.
If you are ever exposed to a splash or a needle stick, protect yourself first. Stop the exposure, wash immediately, and then report it. Do not squeeze a puncture wound.
That thoroughly covers the complex mechanics of infection control part 2. If you can master the why behind these rules, the exam questions become incredibly transparent.
I really do.
And listen, if you want to test yourself on everything we just break down today, you need to head over to certprepacademy.com. I cannot stress this enough. It is completely 100% free.
No sign-up required.
No sign-up required, no paywall, no entering your email to get started. They have a full 70-question practice test that mirrors the real NNAAP exam perfectly, including those tricky prioritization scenarios we just talked about. They have free, comprehensive study guides covering every single topic on the test, and they have amazing flashcards to help you lock in the exact terminology.
Everything you need to pass this exam is in one place, and it costs absolutely nothing.
The link is right down there in the description, so go click it right now. It's an invaluable tool for taking the theory we've discussed and putting it into active practice. Thank you so much for joining us for Part 8, everyone. We know this material is dense, but you are doing the hard work, you are putting in the time, and it is going to pay off massively on test day.
We will see you right back here for Part 9.
Until then, keep studying, stay safe out there, and remember, you've got this.